So today we have Chethan Sarabu, medical doctor trained in landscape architecture, pediatrics, and clinical informatics, with focuses career on designing, developing, and technologies that empower people to better participate in health. He's currently faculty in pediatrics and clinical informatics at Stanford Medicine and the director of clinical informatics at Sharecare. He leads novel research in collecting real-world data from virtual clinical trials using smartphone sensors and integrating this with traditional forms of healthcare data to understand longitudinal outcomes, as well as implement personalized predictive models. Another area of his research and implementation work is in using digital health tools to connect communities and clinics. Finally, he is a founder of Olmsted.health, working on a range of initiatives that connect landscape with healthcare, such as PARC prescriptions. Chethan, so go ahead and take it away, and then I'll, if possible, if necessary, interrupt you later on. But
thank you, Alan, so much. Just one thing, it looks like I am trying to share my slides, but it says that screen sharing has been disabled.
Okay, you can try it on now.
Okay, looks like that should work. Perfect. All right. Okay, you can see the slides, right?
Yep, great.
Okay, and you're seeing them advance?
Yep, it's perfect.
Okay, all right. So thank you, Alan, for the invitation to speak to all of you today. And thank you, everyone, for introducing yourselves. It's nice to get to know everybody. And again, I'm sorry I can't be there in person, but I'm excited to speak to all of you. And hopefully in the future, if there are follow-up conversations, would be happy to come over and spend time in person. I'm normally in California, but just away for a conference this week. So today I'm going to talk to you about pediatrics, PARCs, and prescriptions, specifically PARC prescriptions. And this is going to be the outline of the talk. I'm going to first talk about our healthcare system, the US healthcare system, some of the outcomes of how it works, and try to give you a big picture understanding of some of the language that the healthcare system uses, so that as you think about engaging with it and trying to change it and trying to maybe dismantle it, rebuild it, reshape it, you have more of a sense of the language that the system itself uses. And with that, I'm going to then zoom in to specifically talk about pediatric care, because that is my specialty. But it's also a place where I think landscape architecture related topics come in much more directly. And then finally focusing specifically on particular nature-based solutions that I have been exploring in my clinical and research work. And really looking forward to sharing all of this with you today. And really, I look at this as information that can help stir conversations, discussions. Hopefully it can be educational. And hope it leads to a robust discussion afterwards. And then just to tell you a little bit more, give you a little bit more detail on the things I do and my roles and disclosures. So I have multiple roles that I have. So I am a pediatrician at Stanford, where I work in a community health clinic in Redwood City. And then I'm also an affiliate faculty member in clinical informatics. And clinical informatics is basically a new subspecialty of medicine that is all about how technology and care interact. And then I work for a digital health company called Sharecare, which used to be Doc.ai, and then Doc.ai got acquired by Sharecare, where I work as a director of clinical informatics on a number of projects, really connecting clinicians with designers and engineers, and then also have a few additional tasks that I do as well. On the bottom left, there's a natural capital project, which is a research group at Stanford that tries to look at ecosystem services and does work in connecting urban green space to health outcomes. And so with that, I will keep going. So healthcare today looks a lot like this. This is an actual photo that I took when I took my grandmother to a doctor's visit in Santa Clara, at Santa Clara Valley Medical Center in Santa Clara in the South Bay. You have rooms that are not great environments themselves, from the light, from the layout of the doctor having to face their computer that's not facing the patient. Sitting in this room, the doctor has no context of the patient's life or environment, doesn't know what their home looks like, doesn't know what their surrounding built environment looks like. But this is really where a lot of health care happens. It's not necessarily where health happens, but it is where the formal healthcare system, which currently is valued at is spending $4 trillion or 20% of the entire US GDP, happens and is very broken from a number of perspectives. So we are spending a lot of money in the United States, but we do not have great outcomes compared to other countries. And on a number of different measures, if you look at how long people live, if you look at how healthy people are based on chronic conditions, if you look at the risks of birthing a child, we have all sorts of inequities, a lot of inequities along racial lines, along class lines, socioeconomic lines. So the United States spends a lot of money in healthcare, but we don't get great outcomes for that. And a big part of that is really because of where health comes from. So this is a figure from this healthcare design agency called GoInvo that did the research on all the different factors that affect our health and try to map these out in terms of percentages. So they attribute 11% of our health to direct medical care, which is the slice in red, but 38% in orange is individual behaviors. And they say 7% is physical environment. And I think this is being contested a little bit because oftentimes, your physical environment determines what behaviors you can have as an individual. And so this figure was really made to kind of showcase that so much of our health is determined outside the walls of healthcare. And when we look at that, when we start to look at our environments, we realize there are huge inequities and huge gaps. This was a project looking at healthcare outcomes by expected life expectancy in different neighborhoods in Philadelphia. And just traveling a few miles away from each other around the downtown core of Philadelphia, you have nearly a 20-year difference in life expectancy. And this is due to a range of factors, some which we understand, some that we don't understand. But we realize that healthcare and health is not distributed equitably, it's not distributed geographically. And so there are a lot of efforts going on to better understand why that's the case. And those all involve place-based research. Then if we look at other subsets of the population, my particular area is pediatrics and taking care of children. The United States has a really high child and infant mortality rate compared to other wealthy nations. And it's not necessarily clear exactly why this is the case. We have a lot of theories, but generally one of the big considerations is that we don't really have great social safety net systems for children, for mothers, for young families. And so there are really high levels of childhood food insecurity, maternal food insecurity, where there's not enough food, there's not enough housing. And so those factors do really contribute to overall child health and child and infant mortality. And one of the other things that we're learning about child health in particular and how it relates to adult health is that what happens to you in childhood affects you across your life. And in some ways that's intuitive and we know that, but the healthcare system needs specific research to help really drive change, to drive policy. And one of those ways that that's happening, that understanding of what happens across the lifespan, is really with the research around adverse childhood experiences, or ACEs. This is really the research that's been taking place over the past 20 to 30 years, looking at how extreme events in childhood, such as abuse, neglect, the loss of a parent, and so on, have effects in life later on. And we know not only that they do, but that there are ways to actually change trajectories so that children who face significant adversity have the tools to heal from that and not allow it to carry on into adulthood. And this is really the work of many individuals, but one of the leading voices on it was Dr. Nadine Brooke-Harris, who is a pediatrician who really focused a lot of her career in the Bayview Hunters Point neighborhood of San Francisco. And when Gavin Newsom became governor, she was appointed the first Surgeon General of California, and really made it a statewide priority to understand childhood adversity. And so there's a lot of resources in California that's really leading the way in this. And she has a great TED Talk on it and a great book here if you're interested in learning more about it. But just going a little bit deeper into ACEs, they're very common, and we also understand that it's not just about that initial adversity, but it actually gets under our skin and can change the way children's hormonal systems work, their stress systems, and that leads to physical and mental health changes decades later in life. So we have a deeper understanding of health across the lifespan. At the same time, we are also confronting a deeper understanding and change of health driven by environmental changes, specifically climate change, amongst, as sort of the broad category of environmentally driven health changes. And so there are a number of great books on the subject, and the Federal Department of Health and Human Services and the CDC and the California Department of Public Health and many other agencies do have a lot of great resources highlighting many of the health effects of climate change, from direct extreme heat and air pollution from wildfires can cause a lot of issues, but then there's also a lot more subtle things that may be going on with changes in temperature. We're seeing changes in where infectious disease spreads, where ticks that spread Lyme disease are entering parts of the country that they didn't used to be in before, amongst many of these other health-related issues from climate change that you can see here. And so really, if we look at the healthcare system in the US, there are a lot of questions being asked of how might we do things differently. We are spending a lot of money, not getting great outcomes. We are learning a lot more about inequities in our system. We are learning a lot more about how our health is shaped across our lifespans. We're learning about how our environment shapes our health. And so this is where I would strongly argue that landscape architects are really uniquely well suited to help out and to actually play a central role in shaping everyone's health. And that is because landscape architecture really teaches long-term ecological, multi-scalar, systems-based design thinking with strong roots in public health. And that type of thinking and training is really crucial for not only understanding a lot of the issues that we're facing in our healthcare system, but our health more broadly in society, but it is also really instrumental in trying to help create solutions that can address, that have multifaceted benefits. And so just to rewind a bit, I wanted to share how I got here and a bit of the work that led me here, just to give you some more context. So I studied landscape architecture, but with the intention of going to medical school, all in upstate New York. And what I didn't realize was that landscape architecture training was teaching me more about healthcare than I really understood at the time. learning how to spatially represent information in 2 dimensions and understanding what that looks like in 3 dimensions was a direct task that comes up in medical training. There's a lot of spatial reasoning that's needed. That's just one very specific example, but there is much more around systems design thinking that you get from landscape architecture that really helps shape how you approach health and trying to improve the healthcare system. And so I trained in upstate New York and then in New Jersey, and then moved to California about 6 years ago to get more into the technology side of healthcare. And these were just some of my projects when I was studying landscape architecture, of really going back and forth and using biological systems and understanding urban systems, and vice versa. And also, as a result of work in landscape and navigating environments, also applied that to digital design work. And so just wanted to give you some of the background context of how this came together for what I do today. But with that aside, I want to go back to the US healthcare system and give you a little bit more vocabulary around how to think about the system. And I put healthcare system in quotation marks because it really is a patchwork of multiple elements that we call a system, but it really is quite fragmented. So one important lens to look at the healthcare system is in the people. And there are more people than this, but these would probably be the 3 essential players in this ecosystem. So you have patients, but along with patients, you also have their caregivers and family members who are also supporting patients. You have providers who are the doctors, the nurses, the respiratory therapists, the physical therapists, the social workers, everybody working to provide care to patients. And that happens in the form of an encounter or a visit or a hospital stay. And then you have the payers or health insurance, whether that's public or private. They play a critical role in interacting with both patients and providers. Patients pay payers. You pay, if you have private health insurance, you're paying premiums. If you don't and you have to use healthcare, you have to pay a lot more. Even if you have insurance, you still end up having to pay a lot because of how the system's designed or not designed. And then payers then pay the providers, the doctors and nurses through claims. So this is just some of the language that the healthcare system uses, just to give you a taste of that. And then speaking about insurance, we have in 2020, on the left-hand side, you could see in the United States, 91% of people do have insurance, 9% are uninsured. And that could be a variety of people across the country. And prior to the passage of the Affordable Care Act, almost over 20% of people were uninsured. So that definitely did close that gap there. And then in terms of how people are insured, about 66% of people of those 91% are insured through private insurance, usually through your employer. And then about 34% of people are publicly insured, whether that is through Medicare, which is for people over 65, Medicaid, which is if your income is under a certain threshold, or TRICARE, the VA system, if you're in the military. And it's important, don't really have to get into the weeds of all this. I just wanted to show this all to you, but it's important, I think, to understand, because the way the healthcare system works, all the different programs and services are usually attached to what type of insurance you have. And so that's an opportunity for a lot of inequities to get created. And then another thing to understand is how doctors and hospitals get paid. And this is a big shift that has been happening over the past decade, also started with the Affordable Care Act, the Patient Protection and Affordable Care Act. So on the left-hand side, the bottom left, you see a fee-for-service system going all the way to the right to a value-based care system. And basically what this means, if we boil it down in real simple terms, a fee-for-service system means that the more stuff a doctor does for you, like more surgeries, order more medication, order more tests, the doctor and the hospital will get more money. And that is still largely how our system works today. But if you go all the way to the right to these value-based population systems, the idea is that doctors and hospitals should really only get paid to keep people healthy. If people get sick and weren't being properly receiving preventive care and end up in the hospital unnecessarily, then the hospital and doctors should not be paid for that, and in fact should be penalized for that. And so there's a radical shift going on in the country and trying to change that to actually have the healthcare system try to pay for preventative services. The challenge is in trying to find the evidence for that. How do you know? For example, there are programs. We know that eating healthier food can help delay the onset of type 2 diabetes. We know a lot of people can afford healthy food options, but there are efforts in the healthcare system to say, hey, instead of paying doctors for more money to see a patient, what if we use that money to actually help someone pay for healthier food? So that there are a lot of things like that that are being researched. And similarly, there's a lot of work going on to say, hey, if we pay for someone to have a gym membership, or say, could we pay for a outdoor park that would increase physical activity in a particular neighborhood? If that would decrease healthcare spending, then that's something that the system might want to prioritize. And so there are a lot of research studies going on to try to look at this. And the underlying thing that's driving all of that is this graph here, which is complicated, filled with a lot of jargon. You don't really need to know any of this except to just know the idea that the healthcare system is trying to shift how they pay for things. And that creates a lot of opportunity to change what we actually incentivize and pay for. But a lot of the spending is very disproportionate. There's a lot of inequities, and we see it a lot in children. So right now, in most states, there's a lot going on this graph, but just to summarize, the key idea is that most children in the United States, particularly children who are not white or Asian, have significant numbers who receive care through healthcare through Medicaid and a child health insurance program, which are federal programs, but don't often have the same resources as private insurance. And so there's a lot of inequities in children's care, with most states having nearly 50% of children covered by Medicaid. And so going to take a bit more of a deeper dive into pediatric care. And so this just highlights the different types of pediatric care. So there's primary care, and that's when you grow up, if you had a doctor that you used to see for annual checkups and getting shots, that's really what primary care pediatrics is. But there are many different aspects to it, and I'm not going to necessarily go into all of it, but it's what happens in the hospital if a child is sick, what happens if a baby is born premature. So there's many different areas to pediatric care, but we're really going to focus on primary care pediatrics. And there are, and it's not just about, a big part of pediatric care is understanding where children are, where they're spending time, and understanding what are the opportunities to help with health promotion or to help decrease health risks at different ages based on where children are. And another important aspect of pediatric care is really understanding how children change in their agency over time as they become adolescents and young adults. You have more rights and more agency. And so a big part of our work is in balancing a child's autonomy and agency with parents, guardians. And so just wanted to highlight a couple of different trends and new ideas and thinking that is going on in pediatric care. and then I'm going to take a deep dive in looking at nature-based solutions, park prescriptions. And so one of the new ideas that has been really taking hold a lot is the importance of early childhood development, really the first 1,000 days of life, is a really critical time window where children grow, they develop attachment, they learn language, they learn emotional regulation, they learn to sleep, they learn to drink and feed. And so it's a really critical time window where it's important to provide as many resources as possible. And so a lot of states and programs are really focusing on this group as an important place to focus resources. And then continuing beyond the first 1,000 days, there's a lot of focus around early childhood behavior and development. And there are many companies in this space. And I'm just highlighting this not to endorse any one of these companies. I don't have any financial stake with any of them, but just highlighting that there is a lot of energy and excitement in trying to rethink how these areas of pediatric care are going. And so there's a lot of focus around childhood behavior and development and how technology and reshaped services can help support that. There are also a lot of efforts looking at how schools can become more integrated into the healthcare system. Children spend a lot of time at schools and schools have nurses. However, those nurses are not really connected to the healthcare system. And there was a really simple study where all they did was they allowed nurses in schools to access the child's medical records that the doctors have. And just by doing that, it led to a 2.4-fold decrease in hospitalizations for asthma and 33% decreased trips to the emergency room for asthma for children, because the nurse, being empowered with that information, was able to provide more appropriate tailored care to that child. So there is a huge benefit for connecting data and really integrating nurses into the healthcare system. And I think the broader idea too, to think about this beyond just nurses, if we're thinking about nature and park-based solutions, if we actually have programs that connect children to parks, and there are park rangers, and maybe there are children with certain healthcare conditions that are coming there, if those park programs and the people who support those are to be effective in helping to change some of these health trajectories, maybe there needs to be more connection with the health records and data side of things as well, as we think about not just schools, but also more broadly our parks and places where we live and where health is really created. And these are just kind of highlighting other trends that are happening. And so this is a trend of a program called centering, which is a model of group patient care. Instead of one patient seeing a doctor one-on-one, centering is a model of multiple parents seeing a doctor together and really having that peer-to-peer exchange. And I actually had spent some time with an adult doctor in, I forgot exactly where he is. I think he's in the North Bay, but he actually does centering visits in parks with groups of patients who have diabetes, and leads walks in parks with groups of patients, and allows them to it allows them to talk to each other about their diabetes and get a lot of physical activity. And then another important piece of this is the transition between adolescent to adult care. Usually when you go to college, there is that healthcare system is kind of disconnected from the healthcare system you had before you're in college, or if you're going directly into a vocational trade, there's a huge disconnect between what happens with the care you might have received with your pediatrician and then what happens afterwards. So there are a lot of people who are focused on trying to look at that piece of it. And then I'm going to focus a bit more on the ACEs piece and then talk about parks and nature. And so I mentioned at the start, ACEs, or adverse childhood experiences, are traumatic events in childhood that have effects later on in life. And we are seeing this through evidence across multiple research studies. And we are seeing statements come out from leading health organizations like the CDC and the American Heart Association. The American Heart Association in the bottom right put out this whole paper saying to address heart disease in adults, we need to primarily focus on adolescent mental health. And so it is a radical shift that's starting to happen that understands health in much more context. In the bottom middle, there was an interesting paper. I believe it was a study they did in New Zealand, but they followed about 900 people for 45 years. They looked at their healthcare visits they had in the late 1970s, and were looking at how talking about certain health behaviors in a young age change their trajectories 45 years later. And there was a lot of evidence across multiple areas to suggest that made a difference there. And so we're learning as we're learning about the importance of health across the lifespan, we're learning a lot more about how we can change trajectories. And it's really the framework that has emerged is a framework with an acronym called HOPE, or Healthy Outcomes from Positive Experiences. And it's really things that are quite obvious. It's relationships. If we look at the figure in the middle, it's about relationships, safe, equitable, stable environments, social and civic engagement, emotional growth. They're the things that are obvious that they're important for stable communities, for stable health of communities, and for health of individuals. This is just now being formulated in the language of the healthcare system so that the healthcare system can implement these types of programs, but oftentimes in doing so, to promote a safe, equitable, and stable environment, that requires partnering with cities, with places, with planners, with landscape architects, and trying to do that. And so why I wanted to share all of this is really to highlight the challenges the healthcare system is facing, how the healthcare system talks about things, where some of the energy and new ideas and momentum are, and then trying to connect that to landscape architecture and where you might find opportunities to engage and connect. And so with that, this idea of hard prescriptions is one specific type of health intervention that is directly nature-based, and it's gaining in popularity across the United States, but also globally. And so it comes, I'm going to get back to that slide. So there are a number of studies which have looked at this, and at a simple idea of hard prescription is basically having a doctor or other healthcare provider have or invite a child or patient to spend time in nature, and this looks at whether or not having someone share that, see if it actually leads to increased time. Just 1 second.
Chethan, are you gonna show a video? Okay.
Okay. Sorry. Can you hear me?
Yeah.
Okay. Sorry about that. So yeah, just hard prescriptions are exactly what it sounds like, and so these have been studied with interesting results. This was a study that came in Oakland by Nishani, who's a pediatrician there, and she looked at just a study where children had hard prescriptions and looked at if that led to increased visits in parks and what that did to their stress levels and their resilience, and found that it decreased stress and increased resilience. And it was one of the first studies to specifically look at that. And there have been other studies on this as well. There are studies which, this was an interesting paper, which is trying to look at what is it about nature that has health beneficial properties that improves their health. And this is an interesting study that was trying to look at all the different multi-sensory experiences and how having not just visual vision of nature, but also being there and the sounds and smells and touch and other non-sense based modalities can improve our health. So there's a lot of interesting research going on in these spaces of nature and how nature impacts our health. And so this in particular is turning more and more into an established practice. It's something that I do in my clinic with patients. And there are a couple of different organizations that have been building platforms and practice and how to do this. So this is a tool from an organization called ParkRx America. I can share the websites afterwards so that you have them. And so this is a tool that allows doctors to be very specific with a PARC prescription to actually identify a place with someone, and just like a prescription for medication, to actually be specific about the dosage and frequency, basically how much time should be spent in the park, what should be done there, how often should it happen. And with this tool, it also allows you to identify parks in your local neighborhood. I just pulled up Pittsburgh as an example. And then it allows the healthcare provider to print out information about the park and also tailor it to the patient-specific situation, whether they are looking for something for a mental health condition. Maybe a PARC prescription might be beneficial for them because they are having a lot of anxiety at the moment, or maybe it's a situation where someone needs increased physical activity and they're looking for a PARC that can help with that. So these tools and practice are things that are growing. They're still not super widespread. Not every doctor is doing this, but it's growing more and more. And I'm part of, it's something that I've incorporated into my practice. And I work with a couple of different researchers looking at this, trying to ultimately, one of the things that we're trying to do with our research studies, if we can continue to show that this is beneficial, we actually want insurance companies to put money into this, and potentially that could lead to insurance companies putting money into parks and really improving the built environment as sort of a new stream of money that can go there. And in addition to PARC prescriptions, I also do a couple of other related things, one of which is drawings with children. And so in the top left, you could see at most of the visits, I have children draw where they like to play. And this does a couple of things. It brings the visit to the child's perspective. And it also allows me to better understand the child's environment of what might be going on, of what they like to do, and helps open conversations. So in the top left, this is an example, and this is one that I had permission to share, was one where they had shared that they like to play at church. And that was not one that I would have guessed or asked about right away if the child hadn't drawn it. And then they shared with me that's where they see most of their friends and cousins, and that's where they like playing at church. And at the same time, there's, drawings are a powerful medium that's really child-centered. There are other mediums as well. And so on the bottom left is a tool at Stanford called Our Voice. And this is really a simple app for people to take photos of their environment. And it's a citizen science participatory community empowerment type tool. And we have done some work with them in using the Our Voice tool for patients at our clinic to not only provide drawings, but to actually take photos of places they like to go on walks, or places where they wish they could go on a walk, but find it difficult to, maybe because the sidewalks aren't great. And so we have done some studies and projects together where we implement patient-driven photos for public engagement. And then the diagram in the middle is really just a mock-up of how we might start to see more patient-driven photos and place-based information in electronic health records, and tie all of this together for a better and more holistic understanding of an individual. And And with that, just getting to the end, I hope this idea of park prescriptions was one that helped kind of spark some ideas and thinking of how nature-based solutions can be incorporated directly in healthcare. But really broadly with our healthcare system, what we're trying to do is shift upstream so that there's less, we spend less money once people get sick and end up in hospitals and doctors' offices, but really try to focus that money in our communities, in the places where people live, and the food that we eat, to really focus on the broader systems design of how all of these different moving parts connect together, and to do it in an equitable way. And so with that, just wanted to thank everybody for your time. Here's my contact information, my email and my Twitter. Happy to answer any questions if you email me, but hope we have some time for discussion today. Thank you very much.
Thank you very much, Chethan. I want to open it up to questions. I think your presentation speaks for itself. It's really exciting in a lot of ways. While they're articulating, in the time we have. I think some of the most exciting things about this is the way you've integrated the issues, some of the major issues of the healthcare industry with really a powerful methodology and system and accountability that landscape architecture provides. And I'm wondering if you can tell a little bit more about, shift in that diagram that you had, from acute care management into this accountable system where, whether it's a municipality, do you imagine a municipality, an accountable care organization, some collaboration thereof between the insurance, the provider, and then what is also the role of the landscape architect or the landscape doctor in fostering these kinds of prescriptions and systems of care and stewardship?
Yeah, great questions, Alan. I think for the first one, it's still a transition that's happening, and it's happening in very different ways across the country. You have in a state like Maryland, the entire state actually decided that they wanted to see the shift happen across the state and not leave it up to individual healthcare providers or cities. And so across the entire state of Maryland, there's a concerted effort to get healthcare systems and insurance companies to cause a shift together. Whereas in the Bay Area, it's still really left up to individual hospital systems to change. And you have some systems like Kaiser that have been doing this for a long time, where Kaiser has tried to look at population health more compared to a health system like Stanford or UCSF, which have that to a lesser degree. And so I think it's really, right now it's happening in different ways across the country, and it's hard to point to any one thing that's sort of the trend, but it's just a broader shift to be aware of. And there may be communities where there is more openness to get different players involved. And some of the work that I'm doing with the Natural Capital Project is actually in Pittsburgh, and we are trying to have conversations we're having conversations with hospitals, insurance company, and parks departments, and bringing them all together and talking about this. So it's still kind of a very early stage thing, but that's just an example of how we're bringing some of these players together. And then I think it gets to your second question around what is the role for landscape doctors or for practitioners of landscape in our actual spaces. And I think that's such an exciting idea, and hasn't really been integrated yet. But I think we can look at some parallels in what's happening in things like food insecurity. So a lot of people come into the healthcare system, and the root of a lot of their health issues is that they are food insecure. They might not be able to afford enough food, or only afford food that's low in nutrients. And so healthcare systems have been pouring a lot of money into connecting people to healthier, into community-based services that can provide healthier food options, whether that's food pantries or connecting to food stamps. And so healthcare systems actually provide social prescriptions or food prescriptions for someone to get connected to these agencies. And in many cases, so initially when this started, they would, a clinic might just give a patient a handout that says, hey, you should go try to sign up for food stamps if you haven't already. But that often wasn't really followed through on, or for a lot of people who maybe haven't signed up, that there's other systemic barriers. Maybe they needed help with translating, with trying to navigate the system. All of our systems are so complex. And so what it's led to is a shift to a lot of resources have been put into the healthcare system to say, we need to actually make sure that we help someone navigate all the way through. It's not enough to just say, hey, we're going to give you a pamphlet that says you should apply for food stamps. But how do we actually help connect you to that person who can actually help you do that and ensure that there's follow through on that? And so so this is an analogous example where the healthcare systems are really connecting to community-based organizations, usually food systems. And so you can imagine right now with park prescriptions, a lot of times at a clinic, we might give someone a prescription, but when that person goes to the park, there's no one there on the other end that they might find. And there are a lot of people who maybe haven't spent much time in parks, or maybe parks nearby aren't the safest for them, or they don't know what to do there. And so if we have different practitioners of landscape doctors in parks, and it could be a variety of people. It could be landscape architects. It could be someone who is leading a birding session. It could be someone leading yoga in the park. It could be a park ranger. I think a range of folks could actually are performing services in parks that help improve people's health. And so I think there's a role for the healthcare system to more directly connect the dots there.
Well, thank you for that. Is there any questions? Okay, well, that's right on time. It's 2:00.
Okay.
Thank you very much, Chethan. Let's have another round of applause.
All right. Thank you very much. Yep.